Good morning. It is my great pleasure today to present our work of using GPT to identify changes in outcomes registered in ClinicalTrials.gov. Prospective registration of outcomes help reduce reporting bias in randomized control trials. However, post-hoc changes to register outcomes are common and could reintroduce bias. Such changes are difficult to detect, and past studies mainly rely on expert judgment and implicit criteria, which could be inefficient and non-reproducible. Therefore, this study aims to first develop a structured approach to defining and comparing outcomes using 225 trials with more than 3,000 outcomes registered in ClinicalTrials.gov. We then automated this approach and evaluated the performance of this approach using a separate set of 150 trials with more than 2,000 outcomes. We explored the performance of 3 GPT models and chose the answer agreed upon by at least 2 of the models as the final answer. Built on the literature, we defined an outcome to have the following elements: specific measurement, often the name of a scale, specific metric, the way of assigning a single value to individual, cutoff, the specific numeric cutoff or threshold used to define the value, variable type, whether the value is continuous and or categorical, and time point, when the measurement for analysis is taken. We also developed a structured approach to match and compare outcomes. Here we have 4 examples, each showing the outcomes in prospective registrations on the left and in the last registrations on the right. In the first example, we have cancer-specific mortality listed in both registrations. They are matched with no changes. A new outcome, all-cause mortality, was added in the last registration. In the second scenario, cancer-specific mortality was matched to all-cause mortality with a change in definition for the specific measurement, and the outcome time to disease progression in the prospective registration was missing in the last registration. Scenario 3 shows when a composite outcome in the prospective registration was split into 2 simple outcomes in the last registration. Any of these 2 simple outcomes was considered a correct match to the composite outcome, and the remaining simple outcomes were regarded as added outcomes in the last registration. And lastly, outcomes could be matched, but the definition could be more or less complete, as shown in the last example. So to summarize, we used one-to-one matching. An outcome in the last registration was considered a correct match to the outcome in a prospective registration if it is the best match among all possible matches. Our approach began with downloading data from ClinicalTrials.gov. Specifically, we downloaded 4 fields from the outcome module for outcomes in both versions, and we additionally downloaded 6 fields from the results module for outcomes in the last registrations. We found that the performance improved if we divided the task into smaller subtasks. Therefore, we first prompt GPT to define each element for the 2 versions separately. In parallel, we prompt GPT to match the outcomes. And then for matched outcomes, we prompt GPT or use Python to compare the defined elements. And lastly, the GPT's outputs include the element definition, and the comparison results were rated by human raters in duplicate and independently. Any differences were discussed and reconciled. We have 3 main findings. First, our approach achieved good accuracy in defining outcomes. This slide shows 2 forest plots of percent agreement between the GPT and human raters in defining the specific measurement, metric, cutoff, and variable type for outcomes in the prospective registrations on the left, and for outcomes in the last registration on the right. The red dashed line shows a 90% benchmark, and we could see that all the results are near or exceed this benchmark. Secondly, our approach achieved high accuracy in assessing outcome completeness. Similarly, we have two forest plots here. The results for the prospective registration is on the right, and the ones for the last registration are on the right. And we defined outcome to be completely defined if all of its elements were defined. And we could see that our approach was highly specific in identifying incomplete outcomes in the prospective registration and was highly sensitive in identifying complete outcomes in the last registration. Lastly, our approach achieved high accuracy in identifying changes in outcomes. Here we have a forest plot of sensitivity, specificity, predictive values, and F1 scores for GPT in determining whether an outcome had a change, and an outcome was considered having a change if any of its elements were becoming more or less complete or had a change in the definition. And our approach achieved high accuracy with a near perfect sensitivity of 97% and a positive predictive value of 95%. On this slide, we showed GPT's feedback output for defining the specific measurement for an outcome from the prospective registration of a trial. This outcome measures pain severity using the brief pain inventory severity subscale. And the GPT outputs includes rationale and the answer. From its rationale, we could see how GPT reasoned through the process. It correctly identified that the pain severity is the construct being measured here, that it is subjective construct and that requires a skill for quantification. And it recognized that the text states the brief pain inventory scale, and specifically the subscale is used for the measurement. Lastly, GPT followed our naming convention and produced the output, which was brief pain inventory severity. On this slide, we showed GPT's output for defining the specific metric for the same outcome here. And it correctly recognized that the term change from baseline was an indicator of a change from baseline metric. So to summarize, our approach achieved high accuracy in defining trial outcomes, evaluating outcome registration completeness, and detecting changes across ClinicalTrials.gov versions. It also provides transparent rationale-backed assessments that enable users to review and interpret the basis for each decision. Our approach could be translated to a scalable, low-cost tool that could assist trialists and registries to improve outcome registration quality and help flag potential reporting biases for systematic review and peer review process. Thank you for your attention, and I'm happy to take any questions.
Thanks so much. As someone that has to manually review these changes, I find that even though I sounded like a Luddite earlier, this kind of AI use excites me. Any questions from online? Here we go.
Hi, Matt Koldrick from Northwestern. I was wondering if you could say a little bit more about the training data and what types of, was there any criterion for study type selection, or was it just a random subset of randomized trials or registered trials?
Thank you for your question. I'm happy to clarify. So our training set of 225 trials were a random sample of eligible trials on ClinicalTrials.gov. And the eligibility criteria included phase 3 trials or trials with a not applicable phase. Those trials need to upload their protocol and statistical analysis plan to the registry, and also they need to upload their results to the registry. So those are the eligibility criteria. And when we developed our prompts, we divided this training set into varying sizes of sets, and we iteratively optimized our prompts until no further significant changes were needed.
Okay, thank you. Just another quick follow-up question was, have you done quality checks on the chain of thought prompting to see whether the model's chain of thought is in fact reflective of the model's decision?
We did that when we developed the prompts. So we also provided the model with a few short examples where we have full examples of outcomes, definitions from ClinicalTrials.gov, and we have expert written bullet pointed listed train of thought reasoning. So we provided those examples to GPT, and GPT followed the examples quite well. And when we developed our prompts, we also look at the rationales to see what might go wrong and what we should make changes in our existing prompts.
Thank you.
Thank you.
Hi, Robert Thibault, Coalition for Aligning Science. I'm wondering what your position is on how much the LLMs can do versus how much we should be getting more structured information from people in the first place. Because when an LLM is scraping human-produced information, there's information that it can't get if it's not there. It can guess some of it, but we can't be certain that that's true. And so I'm wondering, having the experience of going through this process, do you feel that LLMs are going to be able to do a lot of this work, or at the same time, do you feel like journals perhaps are going to require more structured metadata, more structured input fields so that we can easily compare and know that we're getting the information from the authors or researchers?
Yeah, thank you for your question. I think it would be definitely helpful if we could have structured fields on registries for each of the outcome element, which would make the assessment more easier and make the registration, which might help trialists to make the registration. Currently, I believe ClinicalTrials.gov requires the registration, the pre-specification of specific measurement and time points on ClinicalTrials.gov, but other elements, I don't think they were mandatory when trialists register the trials. But those like variable type or metric might become more clear when trialists upload their results to the registry, because they have to define those before they analyze the data. Does that answer your question?
Thanks.
Thank you.
Last call.
Really nice work. Randy Ellis, Harvard Medical School. So in the cases that the LLM gets something wrong, is it because the thing that it's missing is not prevalent in the training data?
Sorry, could you repeat the question?
Like, if the sensitivity is like 90% and the specificity is 90%, in the cases where the LLM is incorrect in its classification, is it because what it's missing is something that is just rare in the training data, so it's not super adept at detecting it?
That's a very good question. So we did look at the errors that the large language models make, and sometimes the errors were very apparent. So we thought it should have got it right, but it got it wrong. And the explanation to that is we don't know how to explain that, but we did try our best to provide very specific rules for the large language models to follow. But even after that, still sometimes it makes very obvious errors.